All right, let's run through another case study. So this time we've got a patient with some patellofemoral stuff, IT band syndrome, high school volleyball player, going into her senior year, already committed to play Division I volleyball. So good athlete, having relatively acute pain over the last couple of weeks, really hasn't changed her activity level, really hasn't changed her training. Sounds like she does a good job with warm-up cool-down. So I've seen her previously, probably about a year or two ago, for something unrelated to this. And so she's coming in worried that she's got this problem going into her volleyball season because camp starts this week. I saw her for her initial evaluation last week. So comes in, says that she's been going to physical therapy somewhere else for like 2-3 weeks, not really seeing any improvement, and worried that this is going to become a long-term problem. So asked her what they were doing at previous physical therapy, and she said, well, he's trying to figure out which muscles aren't working and then get them to work. And I said, okay, so how is he figuring out what muscles aren't working? And she said, well, he has me do a squat and then says, okay, well, you're doing this when you're squatting, which means this muscle is not working. And we all know that's not how you assess individual muscle function. And that's not how you, especially with a good athlete, that is not how you assess what's going on here, because she's going to compensate faster than we can see what's going on. So told her, okay, well, that's not how that works. And the reason why you're not getting better is because he doesn't know how to assess what's going on. And I said, well, what is he doing for treatment after that? She said, well, he's trying to activate the muscles. And I said, how's he doing that? She said, well, I think he's using a laser. So not sure how that works, but once again, that's not how that works. So that's why she's not getting any better. So go through screen, she does pretty well. She's got pain with descending double leg squat. She's got pain with descending and ascending single leg squat. She's got pain on landing in a double leg hop, and she's got pain on landing and takeoff on a single leg hop. All her pain is kind of anterior lateral knee. So what does that tell us? That tells us we know that there are certain muscles that should be contracting or facilitated in those motions during those movement patterns, which probably aren't working. So I'm not going to take the eyeball test and say, well, you have pain when you do that. That means you have a weak VMO and you have tight hamstrings. So we're going to strengthen your VMO and then stretch your hamstrings. That's not how it works. So all I've done is seen what her gross motion is, what her report of what is going on is. Now I have to get more analytical and break her down muscle by muscle. So put her on the table, and what do you know? What muscles control pronation that she's having a problem with? Vastus lateralis, gluteus medius, soleus, some glute max, what else? A little bit of foot instability, so abductor hallucis. So go assess those. Those fail. So those are inhibited, which means they're failing contraction at the angle that they should be contracting. Now, does that mean that it's completely giving out and she can't do anything? No. What it means is when I test her, she stutters and she also says, that hurts my knee. So that's telling me that's what the problem is. So when I reverse the inhibition and I come back and I reassess it the second time and say, how's that? She's strong, it doesn't stutter, and she has no pain. So I just got rid of her pain in her anterior lateral knee by treating gluteus medius, which is far away from her knee. So how's that work? Okay. So remember, this is all based on physiology, biomechanics, anatomy. Okay. So go through, reverse that stuff, find some other things, pyramidalis, did some stuff on the other leg, get her up and redo the screen. So now, since I've got these things facilitated, she should be completely pain-free when she does the screen, right? Well, she's not. She still has pain, about 50% less pain, but she still has pain with all of the things that she had pain with before I treated her. So does that mean that we failed? No, that means that she is an elite athlete. She's a Division I commit, which means she compensates really, really, really well. So she's still using her compensatory patterns that she was using before I refacilitated. So Did I do anything that reestablishes or reinforces function on the table with manual therapy? No, none of that has anything to do with manual therapy or with function. I have to get her off the table and now have her do things to get those things to start kicking in. So when I have her do a body weight squat, she has knee pain in the exact same spot. When I hand her a 25-pound kettlebell and say, okay, now the body weight squat hurt, so I want you to do 10 kettlebell squats. And she looks at me like, well, if it hurt without weight, it's definitely gonna hurt with weight. So I said, trust me, do 10 squats. She does 10 squats. The first 2 are a little bit uncomfortable. The rest of the following 8 are pain-free, and she's getting ass to grass. So why is that happening? Because I'm forcing her to use what she hasn't been using for however long this has been going on. So remember, when you add weight, you're making the body use more muscle facilitation. She's only using the minimum amount when she's doing body weight because that's what she's been used to doing. So now I'm saying these muscles are facilitated. We need them to work. So in order to make you use more muscle facilitation, I have to give you resistance. So after we do the kettlebell squats, put that down. Now do body weight squat. Lot better, still has some pain. Okay, fine, not a problem. We still haven't done anything in the transverse plane. So now I have her do crossover walk with the squat, which is heavy transverse plane motion, single leg motion, eccentrically loading, concentrically loading, supination, pronation, okay? So we go through that, then I have her do a double leg squat, no pain. So what did I do by making her use the transverse plane after we facilitated more or caused her to use more muscle contraction by using resistance? Once again, we're making her move in planes that she hasn't been moving well in, that she has been compensating for. Now that she has normal facilitation in the gluteus medius, the vastus lateralis, the soleus, the abductor hallucis, the pyramidalis, all that stuff, transverse abdominis, all that, those all have huge transverse plane components. So if I only had her do single plane exercise, she's a volleyball player. She's got to twist and turn and go in aplanar motions in the transverse plane, which means I have to have her do that in her warm-up and cool-down and her reinforcement exercises. So the exercises that we are doing after we refacilitate are reinforcing function. If you take somebody who has inhibition and you just throw them exercises, the only thing they're going to do is keep compensating and compensate more and more until something else fatigues, and then figure out how to compensate for that and figure out how to compensate for that, which is why most PT corrective exercises fail and actually increase symptoms, which is also why most patients who go to conventional physical therapy that are given a home exercise program that is stretching and exercise get worse. They're non-compliant with their exercise program because they're stretching, which causes more inhibition. Then they're trying to go through ranges of motion with resistance that they can't because they have inhibition, which causes them to compensate more, which gives them more pain and more tightness, which is why they don't want to do their home exercise program. So if you're giving people home exercise programs that are increasing their symptoms or making them stiffer long-term, they're not going to do that. So if they're non-compliant, look at your home exercise program and figure out, did you get to the root cause or did you just throw corrective exercises at them, which is making them worse? All right. So I gave her certain things to work on at home. Those turn into her active dynamic warm-up before practice, after practice. So when she left, she still had this look on her face, well, I still have some pain, which means you didn't fix the problem. I still had pain when I left the last guy. I said, trust me, in 2 hours from now, I want you to redo these exercises, redo those little tests that I gave you, and that should feel better. So here's the difference between conventional physical therapy and 180. Conventional physical therapy, you feel great leaving the clinic because they manipulated symptoms, but then you feel worse an hour or two later, and then you got to go back and manipulate symptoms again. Here, you might still have some pain, some tightness, some rigidity, swelling, whatever when you leave, but an hour later, 2 hours later, the next day, it should be better. Because if I'm giving you things that reinforce normal function and normal neuromuscular facilitation, you will get better long-term, not regress long-term. So she just came in for her follow-up visit on Monday. So I saw her Friday, Came in Monday, she went to volleyball open gym, she went to her weight training program. She had zero pain during those things with jumping, hopping, lifting, running, cutting, jumping, all that kind of stuff, totally pain-free. And she was like, yeah, I feel great. I have no more problems. So that means we just go through the same process that we did on the first. Functional screen, this time everything is pain-free, stability is better, range of motion is better. Check neuromuscular function, had to work on some things. That tells me that those are the things that start the snowball rolling, so we need to reinforce those. Sent her on her way, and she's good to go. So after one visit, we did what she couldn't get out of 6 to 7 visits somewhere else because they guessed, they couldn't get to root cause. They tried to use the eyeball test, then they tried to use corrective exercise. So if you get to the root cause, reverse the root cause, reinforce normal function, now you get long-term functional results, especially when you're working with athletes, high-level athletes, because the reason why they're successful at what they do is they figure out ways to compensate for their limitations, which is why they are good at what they do. So if you have questions on that, post them below. I will see you guys next time for the next case study.